Good morning, everybody, and welcome back once again to the Weekend Wellness Workshop. I'm Dr. Dennis Courtney with you today on this show. We've been covering a topic that will beg to have many of you come to be very much interested in. Last week, we had a guest on our show who literally got the whole ball started a number of years ago. His name was Dr. William Butch Schrader. Now, as so many people end up trailblazing and starting the trail, others then pick up en route and take over and sometimes surpass the original guy who started this on our journey. A similar thing may have happened in this particular case. We're going to be talking to a gentleman today who has become the rock star in immunotherapy, following along the footsteps of Dr. Schrader, but really bringing a capability to immunological therapies heretofore never seen. So I want to spend some time today with our good friend, Dr. Vincent, who hails from Wasilla, Alaska, and has the unpleasant task of going to the Kona coast of Hawaii 2 weeks out of a month. We happen to be catching him in his Kona coast venue at the present time. I want to say, I think it's good morning to you, Dr. Vincent. Good morning and welcome aboard today.
Hi, good morning. Thanks, Dr. Courtney. Yep, it's 6 hours earlier for me than it is for you.
Well, I'm glad this is working out so well. I had a chance to see you just a couple of weeks ago, and naturally, you were the hit of show. Your topics were what everybody came for, and I'm always of a mind to bring to my listeners the hottest information I can on the most current therapies out there that are available. This particular case is probably the epitome of that. I would probably want some of my listeners who don't know you, by the way, that's very few. Many of you already are known. You are known to many of them already. But why don't you bring us up to speed quickly on your background, Dr. Vincent? You are conventionally trained, but you took off on your own journey not too long ago. But take us up to the point where the takeoff occurred.
Okay, I graduated from family medicine residency in Anchorage, Alaska in 2005. And I think I started to deviate from conventional medical point of view before I even started medical school in 1998, though I was interested in Andrew Weil's work and was learning about nutritional biochemistry and things on my own before starting medical school. And then I was sort of horrified by the lack of understanding of those things all through medical training. My third year of residency, I actually had the opportunity to learn acupuncture and Chinese medicine through the Helms Medical Institute, medical acupuncture for physicians. And that was probably my first formal, I guess you could say, deviation or enrichment of my medical knowledge base and understanding of things and broadening of my perspectives on health and wellness. And after working with a group practice for a year and a half, post-graduation from residency, where I delivered babies and did colonoscopies and managed my own ICU patients and full spectrum family medicine, I decided I wanted to focus on chronic complex medical illness and open my own clinic, which has now been about 8.5 years. It'll be 9 years actually at the first of the year. So that was where I really got the opportunity to learn more and do things differently. And I wouldn't necessarily say do things my way, because my history has been that my way of doing things is different from year to year, which is my interpretation of progress, actually. So I connected with a number of national integrated medicine organizations like the Institute for Functional Medicine, American College for Advancement in Medicine, the American Academy of Environmental Medicine, where you saw me lecture a couple weeks ago in Florida. And I actually spent time on the board of those last two organizations, 4 years on the board of AAEM. And I managed to pick up lots of additional skills and techniques along the way. I think I learned LDA from Dr. Schrader, as you mentioned, you had him on last week. I think I learned LDA from him about 7.5 years ago now, when I first picked that up. And I remember sitting in that workshop and being absolutely just awestruck by what I saw as the potential for that treatment. And I just was really thinking about allergies at the time, because that's what the focus is. And I used it for strictly allergies, using the standardized mixtures for the first year or two. And then I started to realize that the technique, just understanding the technique and what you could do with it to deprogram unnecessary inflammatory responses in the body or hypersensitivity conditions, you could apply to a myriad of chronic diseases that we see today. And I just sort of started experimenting with it, basically. And I'll have to go back and hear what Dr. Schrader had to say about me.
Yeah.
So,
believe you me.
He and I are good friends.
I know.
We work together and have a good understanding of one another. But he does a lot of shaking his head and scratching his head at me when I talk about the things that I do differently with his therapy at this point.
Well, let's just say, in retrospect, talking about his therapy when it was strictly a classical allergy therapy, I was awestruck, as were you, when those concepts were first taught to me by the Godfather himself. It's a pretty big day, I think, in all of our lives. And so when you were using it for classical allergies alone, you were getting the same successes that we all get, right? I mean, you're having great success with it, weren't you?
Sure, yeah. It seemed to work great for people who had previously had really no solution to their problem.
Well, and those allergies can get, so overplayed and involve so many systems that to have a way to completely reverse them definitively and literally almost be able to use the C word, you know what I mean, the C word, with these people
Right.
with terrible allergies, what a great capability that it puts in the hands of doctors like you and myself to help people out in that way. And if we did nothing but the classical allergies alone, I certainly would have been completely happy with that. But of course, Dr. Ty Vincent is always thinking out of the box. Let me ask you, you saw a different future out in front of you that nobody had really explored, especially to the extent that you have, where you began to look at LDA, low-dose antigen therapy, to treat other kinds of disease. What was the allure for looking outside the box? And as you moved outside the box, what hurdles did you have to surmount to begin to develop and ultimately achieve what I'll tell you, ladies and gentlemen, is a success rate, bar none, that's nothing short of miraculous. But take us back to those early days, Dr. Vincent. How did things go when you make the twist?
Well, the first two things that struck me as I should be able to treat them with this same technique and skill set, I can't remember which one came first, honestly. One was yeast hypersensitivity. Like you'll see patients who are extremely ill from what looks like candida infection or candida or yeast overgrowth, but you'll treat them with antifungal therapy and they improve dramatically while they're on antifungals. And then as soon as you stop them, even if they've been on it for months, as soon as you stop the antifungal therapy, they're sick again within 2 to 3 days. And it started to dawn on me that was evidence of hypersensitivity to the yeast, not an infection per se or an overgrowth of the organism, because they become sick again so fast. It's just that trace amount of recolonization the patient experiences within a couple of days off suppressive therapy is enough to make them ill. That has to be a very heightened response. So I purchased some candida strains and baker's yeast and brewer's yeast I decided to throw in there because a lot of those folks seem to start to cross-react. And I just made my own dilutions out of the yeast based on my own style and my own thought process about the territory in which LDA sort of works. There are other styles of immunotherapy or desensitization where you can be creative and use any antigen you can think of. And classically in environmental medicine, when we do what we call provocation neutralization, we make 5-to-1 dilutional steps. But the LDA mixtures are diluted more like 10 to the 10th, 10 to the 15th territory. And I thought, well, if I'm going to use the antigen therapy in that manner, I need to go to that realm of dilution. So I made 100-to-1 dilutional steps and labeled them 1C, 2C, 3C. So I started that way. It just made sense to me. And now that's the language everyone is stuck with if they want to be able to communicate with me, for better or for worse. So that was incredibly effective. I was so amazed at how well that worked for people that had these sensitivities to yeast problems. And I started to see them all the time. And it's interesting, every new application I've developed for this, before I realized that it might be an application, I would see these patients and not even realize that was their problem. And then once you have the tool in front of you, and I hear this from my proteges now who are using LDI, they quickly realized that they can use this for all these people, the people that they've seen for years, that they didn't even understand before part of their chronic problem was inflammatory or hypersensitivity based. And now they have this whole new perspective, like, wow, I have all these patients lined up that might benefit from this now. I can think of person after person. So I started using the yeast first as far as standardized antigens go, which has been modified once or twice since then to expand the number of species of Candida. And it works better now. But the other thing that I figured out very early on was the concept of just global desensitization. Like when we use the LDA mixtures, the foods, for example, the food cocktail we use has a couple of hundred different food items in it. And the chemical mixture has hundreds of different chemicals. And so the idea is it doesn't really matter which one or which 20 or 30 items in the mixture that patient in front of you is sensitive to. It's this shotgun approach, and the ones that aren't relevant are not relevant. And so I thought the next person that I explored this with was someone with inflammatory bowel disease, chronic inflammatory colitis. And she wasn't responding to the food mixture very well or anything else that she tried. I actually did her first colonoscopy myself and made the diagnosis, believe it or not, for this patient back 10 years ago. And so it occurred to me that I know where the cause of her inflammation is. It's in her gut. I just don't know what it is. And based on the shotgun, broad global approach we learned with LDA, I thought, well, I can just take a stool sample from her and I should have whatever that trigger is in that mixture. And if there are a million other things in there that don't matter, it just won't matter. So then I had to try to figure out, well, okay, how do I do that mechanistically? And I had read around that time I was at another environmental medicine meeting, and Dr. Bill Ray, kind of the founder of the modern environmental medicine association in America, he was talking about, he just briefly mentioned during one lecture the idea of what he called autologous vaccines, where they would desensitize people using the provocation neutralization structure to their own snot or their own urine or their own feces or whatever if they had inflammation in that body cavity. I thought, wow, well, that's exactly what I've been tossing around in my head. And so I caught him at a break and I said, how do you do that? And his first response, well, it's somewhere in my second book, where he's got these 4 giant books that he's written over the years. I was like, I'm not going to go slugging through that looking for this one answer. And I said, no, like, what do you use to sterilize it? Just tell me that. Like, I can figure everything else out. And he mentioned millipore filters to me, which I'd never heard of before in my life. And then he walked off. And so that was all I needed. I just needed a little bit of information. And I looked up what millipore filters were, and I got them, and I figured out all you do is stick it on the end of a syringe. So you have your dirty solution in the one syringe, and then you attach the filter, and as you pass it through into the next sealed vial, it becomes sterile. It's called cold sterilization. So I started experimenting with that, and this first patient who had chronic colitis responded significantly to a 6C dilution, which is 1 part per trillion, or 10 to the 12, of her own stool. And I thought, there you go. See, the concept holds. And scientifically, which I'm a devout scientist at heart, we like to feel like we know things, right? We want to feel like we have answers and understanding. And I've really had to let go of that to be able to broaden this treatment the way I have, because I have no clue what it is in her stool that she reacts to. And the reality is I don't have to know. I just have to know that that's where the trigger is. And then I had other patients, first people I did what I call autologous desensitization, whether autologous LDA or LDI, were inflammatory bowel patients. And I had some incredible immediate remissions in people with, bloody diarrhea and just horrible colitis and whatnot. Just immediately their symptoms would shut off. And it was like magic for a lot of these people. And then I started to realize that I can use this for pretty much any kind of autoimmune process as long as I can obtain a sample. And it sort of went from there with a lot of autologous therapy that I played with for years. And then I started to realize that it's even better if you can identify what the organism is, because most of these are microorganisms that set them off. And so then I would do research on different conditions. Say, okay, well now, one of the most recent ones I sort of have hit on is that vitiligo, the condition that's autoimmune where you lose patches of pigmentation from your skin. Pretty minor, but it's disfiguring and socially disabling for people, honestly. That seems to be associated with the bacterium H. pylori that lives in the gut. So we have a couple of people, I got a sample of H. pylori, and we're desensitizing with it, and their pigment is coming back in their patches of vitiligo. Wow. That's sort of the most recent kind of fun one. It's not a disabling condition, but you can do research and you look up molecular mimicry and the disease name, and you get some possible associations to try. And I have now, I think, about 16 or 17 different microorganisms that I play with and have available to people for a variety of different sorts of chronic autoimmune or inflammatory conditions. It's been quite amazing in the last couple of years.
Well, now, I mean, just sort of recapping, and I hope my listeners really appreciate, and I'm going to help to decipher some of this. So any kind of allergy correction, even done in conventional world, starts with the antigen itself. And of course, these are usually obtained in conventional ways where, you actually go get small dilutions of whatever allergens are out there in the cosmos. You took another step, and I believe that step is enabling you to open so many locked doors where you said, hey, if whatever is causing this particular patient this set of problems, this set of complaints, the antigen that's provoking this is found within this very person themselves. I don't have to go outside. I can go inside. I can get body fluids, fecal matter, or urine, or oral saliva, or I even think you use skin, and you can come up with a mixture of antigens that you just said, maybe a shotgun approach, but in there somewhere is the one organism that triggers this person's problem. And without the headache of trying to figure out what that is, you can actually, I guess the word stumble across it is a fair word to use, isn't it?
Sure. It's the bombing approach rather than the sniper approach, I suppose. Except the beauty of it is there's no collateral damage. I guess that's a terrible analogy, because if you bomb a city, there's collateral damage. You didn't just take out the target. With this approach, the safety factor is paramount to the success. I mean, it does not make any difference if you are attempting to establish tolerance for antigens the person already tolerates. And that's why you can get away with this with virtually no risk whatsoever. I mean, the risk of using this kind of immunotherapy is all about dosage. If you give a person a concentration that's too strong for their particular case, their symptoms will flare up. And that just means you wait till that calms down and reset the cycle 7 weeks later, and then you give them a weaker dilution, and you find what solves their problem instead of makes it worse. So it's very user friendly, honestly.
Absolutely. I think too, to identify the fact that you've moved in a completely different realm, the letters LDA had to sort of change because of your influence, because we now use a designation of LDI. Tell us about this differentiation between LDA, which is where it all started, to where it seems to be going, which is LDI, and certainly because of your influence, needed to go there.
And that's a good question. Honestly, this whole thing, some of your listeners probably know, started at EPD in London. Dr. Len McEwen, who I had the pleasure of meeting a couple weeks ago in Florida, came from London for that conference. He figured out the beta-glucuronidase, affecting tolerance and the immune system and everything back then, and called the first permutation of this enzyme potentiated desensitization. And Dr. Schrader was importing that to the United States until the FDA decided that wasn't okay anymore in, I think, the 1990s sometime. And then by the late 90s, he had to remake it in the United States through a particular pharmacy, college pharmacy, that sells these antigens to us. And he changed the name to low-dose allergy therapy. Then when I was developing all of these new antigens and was deciding that I could distribute the mixtures to other practitioners who wanted to use them, I thought, well, I have to call it something else. You can't, because college pharmacy has sort of a patent or a copyright of that name, LDA, low-dose allergy therapy. So I decided to use what I consider to be a more blanket term that is really sort of like what EPD means, describing what we're doing as low-dose immunotherapy. And that, in my mind, encompasses LDA, which is also a form of low-dose immunotherapy specifically to treat allergies. But it gives you liberty to include any antigen that you might want to use that isn't necessarily what you would call allergy. Also, autoimmune diseases and other inflammatory processes. Like one of the recent ones we've had huge success with is just simple acne. And that works beautifully, desensitizing people to a collection of skin bacteria. And you wouldn't necessarily call that an allergy or an autoimmune disease. So I've started to think about these conditions more in a general term of immune-mediated condition, and then all of those can be treated with LDI, conceivably.
Well, we go to a conference now, and it's like there's this division. We start out, and Dr. Schrader's talking to us about LDA, and then there's a break, and you take the stage, and the rest of the conference has to do with LDI, the immunotherapy component, and it was just a great place to go. Dr. Schrader did so well with his classical allergies that that was already a battle won by that gentleman, and he needs to be saluted so much for it. But he didn't take offense to you taking the stage. I got to say, you can tell that he does it with a wry look in his eye and a nod. He enjoys watching what his therapy is becoming. And I just have to tell you, I wanted to share the fact that I can certainly see it, and we all can see it. He looks at you as a protege that is picking up where he left off, and you're the right person to do it, Ty, and you've done a great job in doing it ever since. Now,
thank you, and my hope is that other people will do the same. Will be able to take what I've done and expand upon it and take it in new directions too. I really see this as a collective effort, many of us.
Well, we've moved into the arena where certain diseases that are plaguing people can now be conquered by literally allowing them to give us the means by which of doing it. This concept is newly born, really, and strictly under your tutelage. We got a long way to go, and you are very open to the group and wanting input and wanting them to take over, so that if there's another one coming behind you, Ty, I'd hate to see what heights we can surmount, because we're doing quite a great job of them right now. Here's what I want to do, though. I want to take a short break, and when I come back, I want to have a chance to move into an arena of autoimmune. I think in our last conference, you blew us away. This was only a year ago when you began to talk about something called Lyme disease and your success rate with it. It really put this whole concept on the map. But the idea of what autoimmune disease is, I believe, should be where we pick up and begin with part 2 of our conversation today. You okay with that?
Oh, absolutely. I'd like to clear some things up from my perspective for people.
Okay. So, ladies and gentlemen, you're with Dr. Ty Vincent today, the originator of something we call LDI, low-dose immunotherapy, and under his direction are moving with leaps and bounds through helping people that never been able to help before. No better category to discuss this difficulty in helping people than autoimmune. We're going to take a break and come back to open up with what autoimmune disease is and what some of the successes have been with Dr. Ty Vincent's treatment realm in the use and against autoimmune disease. So we'll be right back in a moment after a short news break. We will return. Good morning, ladies and gentlemen. Welcome back once again to the Weekend Wellness Workshop. We've been talking about a unique set of therapies we offer here in Western Pennsylvania. All started with a gentleman, you met him last week, Dr. William Bush Schrader, but the disciples of Dr. Schrader march on. And there's no greater representative of where the sky is the limit than what this gentleman, Dr. Ty Vincent, has done with those therapies to move us into the ability to help more people in a more definitive way. We started our conversation talking about autologous antigens and how beneficial they were, where we could literally round up the bugs that are causing the problems for that particular patient within the patient. Now we're going to move our conversation to another realm. That's to discuss, and Dr. Vincent, thanks for staying aboard with us. Let's discuss something referred to as autoimmune disease. Now, could you please, for our listeners, describe in the best way you like to explain it, how you view what autoimmune disease is, and in so doing, the openings that has provided you with attacking autoimmune disease through this newly found treatment we call LDI?
I'd love to have that opportunity. Thanks. The classical or historical viewpoint of autoimmune disease, as the word implies, is that the immune system is attacking yourself. Auto meaning self. And that's true. The problem is that's the downstream effect of what started it all. What we know now through, research in various specific disease entities, and through my own work has become extremely obvious to me, is that autoimmune diseases in virtually every instance actually begin with an immune response against something else that is not you, something that's non-self. And then it evolves by cross-reactivity, or the concept of molecular mimicry, we call it, whereby the immune system can't distinguish between one of your own proteins on your own tissue and a protein on the target microorganism. It's almost always a microorganism that sets these off. One good exception to that is gluten. Gluten, found in grains like wheat and rye and barley, can trigger autoimmune reactions as well, because there are similar protein structures in the gluten as a target. Close enough resembles some of your cell tissues that you get, like celiac disease, for example.
Mm-hmm.
But, one of the classical autoimmune diseases that was discovered and described was rheumatic fever, right? And for quite a while, people just described the features of this fever and these red blotchy skin rashes and arthritis and heart inflammation and bowel deformity over time. And then it was discovered eventually with microbiological techniques that, this whole thing was set off by Streptococcus pyogenes, strep throat. And as long as you get rid of the strep throat infection within 10 days using penicillin, you prevent the development of rheumatic fever. So that's a great, prototypical autoimmune disease that we know to be 100% caused by a bacterial species. And it's really that the bacterium causes this prolonged inflammatory response if it isn't put in check quickly enough, that then evolves to include a reaction to the person. And now we know there's published evidence looking at molecular mimicry from many different germs triggering many different inflammatory conditions or autoimmune diseases. For example, Crohn's disease, inflammatory bowel disease, was labeled by Dr. Crohn, right? Eponyms are riddled throughout medical history. Mm-hmm. And really that tends to be a reaction to mycobacteria in many cases, not all. See, this is one of the autoimmune diseases I've treated that I have found to have various different triggers. It could be yeast, it could be foods, it could be Mycobacterium avium paratuberculosis, which is kind of the specific one most often associated. And I know that because I purchased a sample of that organism plus a couple of other mycobacteria. And when I desensitize patients who have Crohn's disease to that bacteria, their symptoms usually get dramatically better. So it gives this tool that I developed with LDI, gives me a chance to prove cause and effect. So I can go beyond what the published literature speculates about these diseases and actually put it into practice. So multiple sclerosis is a great one. That one people are having with more and more regularity in the last 20 to 30 years. And since you mentioned Lyme disease before the break, that has responded in every case I've attempted so far to the Lyme disease, the Lyme bacteria mixture that I put together. So in my mind, multiple sclerosis, sure, it's an autoimmune disease, but it is set off by Borrelia or other co-infection type of organisms in the Lyme spectrum, in the vast majority of cases at least. And having that kind of knowledge and being able to build upon this is giving us more specific tools to stop and even reverse many of these devastating conditions. And like you said, I'm hoping that the sky's the limit on this, that pretty much every autoimmune disease, eventually we will identify what the specific triggers are, because as I mentioned before, using an autologous sample for someone is a bit of a shotgun approach. But if I know what the triggering organism is for that person and I have it available in a standardized fashion, it works far better. So if I have a Crohn's disease patient, for example, and they have some response to their autologous stool, LDI desensitization, we usually respond much better if I give them the mycobacterial species itself. That's the trigger. That's the sniper approach versus the bombing approach. Mm-hmm. And you're just more likely to hit the target. And we have, like I mentioned, vitiligo seems to be related to H. pylori. We have a mounting list of these things that now blur my definition of autoimmunity. We described the term autoimmunity based on observation of symptoms people had and being able to identify in some cases antibodies or immune response molecules that were targeting the person themselves. And it came later that we had understanding most of these are set off by something else. So is it really autoimmune, or is this something that starts off as some sort of protective mechanism against a microorganism that goes awry, goes astray? And in the modern era, we have seen a huge spike in autoimmune diseases, the ones we call autoimmune diseases. I mean, I myself contracted type 1 diabetes, which is autoimmune, at age 39. And that's not supposed to happen. It's supposed to happen when you're like 5 years old or 9 years old, not when you're 39 years old.
Sure.
But so I've experienced this myself, annoying as it is. And I'm on a quest to figure out what the triggering organism is for me in my case, to see if I can reverse that for myself and perhaps thousands of others.
Now, I'm going to harken back to talk about Lyme. You know, I can't ever forget having you take the stage a year ago. This is October 2014, where you made the revelation that the reason why we had not been successful in treating Lyme disease is because it continually was viewed as a microbial infection, which in fact, it always starts out as a microbial infection. It was this awareness, and you were the first to bring it to the forefront, that this is maybe initially an infectious disease, but this is an autoimmune disease. And it was that revelation that allowed you to develop various mixtures and antigens that could definitively stop it in its tracks. I heard you say a moment ago, and I don't know if I've heard it correct. I heard you say there's not been a Lyme's patient that you've come across that you haven't been able to be. I'll let you fill in the blank. I don't want to put you out on a limb. But you mean to tell me that you got a 100% success rate with Lyme's disease?
No. What I had said was with multiple sclerosis, with MS patients, all of them that I've tried the Lyme mix on have responded to it.
Okay.
But by no means do we have 100% success with your quote Lyme disease cases, and there are various reasons for that. Some of it is that, of course, that's not their actual diagnosis. You know, you don't know that until you try the antigen all the way through the spectrum and then maybe try something else. And what you had thought was Lyme disease, they actually respond to Epstein-Barr virus or mycoplasma or cytomegalovirus or varicella virus or streptococcus. Like the immune syndromes that are set off by those other microorganisms look for all the world, like Lyme disease in many cases. Fatigue, brain fog, weird widespread pain conditions. And so a lot of the people that come to me saying, I have Lyme disease, maybe not a lot of them, but there's a percentage of them who actually don't have Lyme disease. And they have a reaction to something else, which is complicated to figure out. You have to go through a whole trial and error process of trying different antigens to score on the right one.
Let me ask you this then, to hit this directly and head on, because we've had so many phone calls since our last show on Lyme disease in particular. It's such a rampant disease. It's everywhere, Ty. You can't turn your head without finding more cases of it. So what's the batting average look like? It's now a year plus since you took the stage in October 2014. What's the status report on LDI in treating Lyme's as you see it?
Right. You know, I get asked that all the time. And the first 50 people we treated in my own practice in Alaska, we kept track of them really well. And only 2 or 3 of them failed to respond to the Lyme antigen mixture. And, you know, for a couple of them, we actually got responses later and whatnot. So I was telling people conservatively there was like a 90% or better response rate.
Phenomenal.
Oh, it was amazing. And some, you know, but then you have, it begs the question, how do you define response? And anybody who tells you they have a certain response rate for anything, you should really ask more questions. Okay. Don't take the used car salesman at face value. So response to me means that it had enough improvement of their symptoms that it made it worthwhile for them to want to continue doing therapy. It doesn't mean 100% resolution of their symptoms. Your Lyme disease people are very complex because of the immune dysregulation that occurs in this chronic immune-mediated condition. They often develop food allergies, yeast sensitivity, chemical sensitivities, all these other things that start to contribute to their chronic symptoms. So to think that just the Lyme bacteria mix alone is going to take away all of their symptoms isn't often the case. Sometimes it is. We've had plenty of people where the Lyme bacteria mix, they get 100% resolution of their symptoms. And now we've been treating some of them for a year and a half, and they only need a dose every 3 or 4 months, and they're like in full remission in between doses. And that's beautiful. That's what we hope to achieve for 90-95% of people down the road. Now, since then, I personally have probably more like 450 to 500 Lyme patients that we're treating myself. and have not continued to track statistics like we did with the first 50. And the complexity of the people that I'm seeing is far different than the complexity of my first 50 patients. Because now I see people all around the country, and we've been able to mail treatment to them, and it's not as direct a contact. A lot of them are within the first 6 months of their treatment protocol right now, and sometimes it's taking that long to really start to hit your stride and get good responses. So I do not have a good assessment of success at this point, but I will tell you that it is less. And the reasons I see that it's less are a lot of these people are more complicated, so it's taking longer to figure out what all they need besides the Lyme bacteria. Number two, a lot of them don't have Lyme anymore, or they never were triggered by Lyme. I have no way of knowing that. And so we try the Lyme mixture down to, all the way to the strongest end of the spectrum, and it has no effect. And then my opinion is, well, then it's something else. I mean, it's not that the Lyme antigen failed them, it's that that's not what's causing their symptoms today. Could have been 10 years ago. The other issue is personality. And this is a touchy subject, but a lot of the chronic sicker Lyme people that, have contacted me from around the country have been people that have been sick for 20 years, and they've tried every therapy under the sun, and they have become so fearful of flaring and fearful of failing another therapy, they're afraid to hope anymore. And some of them, we cause a flare from a dose that's too strong, and they quit doing therapy because they're like, I don't want to take another thing that's going to make me worse.
All right.
And it's agonizing to me when that would happen, because if their symptoms flare from a dose, that means it's the right treatment. That means that we scored. We have the right antigen. It just means that person's more sensitive than we suspected. And if we could take the opportunity to make the antigen dose weaker for them, you would find the dose that makes that person better. And that has happened quite a bit. Not lately, because as I talked about in Florida a couple weekends ago, I figured out how we can do rapid dose titration from a safer dilution point. But a year ago, we were giving everybody like a middle of the road dose because we thought we had to wait 7 weeks every cycle, and we were balancing risk with time efficiency. So about a year ago, when I was starting to see a lot more of these sicker people, we were causing flares probably 30, 40% of the time, first dose out of the hat. And a lot of those people were like, I've had enough of things that make me worse, like antibiotic therapies or whatever, and they would just bail out. And so, but they have to be included in your denominator, right? I mean, if you're being honest, that counts as a failure because what you did to them scared them off. Now, though, if I had an opportunity to treat that same person again with the dose titration approach, we would almost certainly not have that outcome. We would find the dose that worked for them and get them doing better. And that's so it's hard to say what's your success rate. My optimistic belief, rather, is that if people are patient and stick with me, and we get to work through all the Lyme antigens, and then if that's not it, we work through anaplasma, Epstein-Barr, influenza, whatever else might be the trigger for them, I'm pretty sure I can figure out the answer for 95% of people. But that's not reality, right?
Exactly. We're going to take a short break and be back with Dr. Ty Vincent. Be right back in a moment. Good morning, ladies and gentlemen. Welcome back once again to the Weekend Wellness Workshop. We've been talking with Dr. William Bush Schrader. So the take-home message that I continue to want to bring to my patients is the worst thing you can tell me after I do these injections is that nothing happened. Do you want to take and explain that? Because that really is the key. When nothing happens, that's not good. When something happens, good or bad, that's great.
Yes, correct.
Mm-hmm.
And I try to get better about explaining that to people up front. Like, even if you flare, that is a positive response for the long haul. It sucks for the next couple of weeks. Granted, you're going to feel bad for a week or two or a month, but it means that we have the right answer. It is such a wonderful thing. And like early on, when I experiment with different antigens for different conditions, and I have no idea if I even have the right target, I get extremely excited when I can cause a flare, because that means I found the right answer. But with the Lyme people, now we sort of have a stronger feeling like this is the right answer for you. So we start really weak and we approximate their dose from a safe distance. But you're correct in saying the only negative outcome is no response. That's the only failure in my mind. that it didn't work. That means no flare, no response, no nothing. It was dead. Then you move on and you try to find the next antigen, is my plan. And that means that LDI isn't necessarily going to fail. That it just means that it wasn't what you thought it was at the outset.
Perfectly said. The it might be inside ball game, but I'm just dying to ask you, as a fellow clinician, when somebody has that flare, and these flares are pretty doggone devastating. They can be just terrible for them. Do you intervene and snap the flare using prednisone, which I believe we're supposed to be able to use? Do you oftentimes revert to that in order to stop the flare, or do you just let it work itself out? That's a doctor-to-doctor question.
No, it's a very big patient question too, and a lot of the patients who have Lyme disease have very strong biases against wanting to use prednisone, either because of their own experience or more often because of things that they read on the internet. I will tell you, I hardly ever give anyone prednisone anymore because we do the dose titration trick where we start really weak. And if we do end up causing a flare, it's very mild and short-lived. And I haven't had to give anyone prednisone for a flare in quite a while. But early on, when we were giving people a middle of the range dose, we would see people flare, like you said, very aggressive flares. Their symptoms would get so bad they were bedbound and absolutely miserable for up to a month. It depended on how far off we were from the correct dosage. If we were a million times too strong, they may flare badly for a month. And those people would oftentimes gladly accept the prednisone to calm the flare down. And in my experience, that worked very well. I've only had one bad outcome giving people prednisone. Probably gave prednisone to 100 people through the course of this, or 100 times, let's say, because for some people they would flare several doses in a row as we tried to find their dose, and they'd take prednisone each time. But I've only had one negative outcome where, upon stopping the prednisone, the person's symptoms all really blew up in their face and just stayed that way until we got their LDI dose right. So that's the reason why a lot of people want to avoid it, is they fear the rebound effect when they come off of it. But the vast majority of the time, we got away with it just beautifully without it causing any problem like that. So it's a tool that folks have at their disposal when you're treating Lyme, and if you do cause a flare, you can calm it down with prednisone with a great level of success.
Glad to hear that it's still in play. Because I'd love to be able to have that discussion ahead of time, saying, if I do this and we get a bad result, I can help to take it away almost immediately. And I just want to make sure I asked you the right question. You would still use it to this very day is the take-home message I'm going to leave with, if the patient is amenable to it, if I think I heard you right. Correct?
Yes. Yeah, I would use it without any real fear about the repercussions. We had the one case. She's a very special case, incredibly highly sensitive with very severe symptoms at baseline. And most of your people aren't going to be like that. And most cases now, if you follow the dose titration protocols in my newest version of the manual, you're not going to see these really severe flares in people. But that being said, we have about 125 LDI practitioners now around the country and in some other countries using this. And I hear about a lot of their practices firsthand. A number of them are starting people at very strong dilutions, and they're not following the protocols that I've tried to bring to people. They're just hammering them with a strong dose and continuing to give them the strong dose, thinking that it's going to work eventually. And that is not how this seems to work. And the patients are suffering under that assault from certain practitioners. So that your listeners should be aware of that really you want somebody who understands that you want to start at the weaker end of the spectrum, things like 15C, 18C, way out diluted, not 6C or 7C. And I'm still hearing these stories from some patients. So you might want to ask your practitioner some very pointed questions about their use of this technique before you start.
Well, enough said. Now, I left, as I usually do, after a conference with you, my dear friend, and on my flight back, I had my trusted little LDA book, and I started going through and jotting some notes. And here's what I found. I found that there were 41 different conditions. I don't know if you've ever counted them up. there were 41 different conditions that you now have successfully treated with LDI. And some of these are very bizarre and rare, others are more common. But do you mind if I start tippy-toeing down this list? It may trigger you to bring an interesting antidote in, but I have documented that you have successfully treated every one of these with LDI because, well, it made it to the list, and I wouldn't have put it on here without that happening. So could we take a little trip down memory lane here?
Yeah, I've never counted. I'm actually fascinated by that number.
I counted the number. It's 41, Todd. By the way, who knows what it'll be next year, right? But as of this year, it's 41.
More than that.
All right. You started out, by the way, you mentioned sarcoidosis. You had patients that you treated with sarcoidosis, more than one, and then you got an excellent response. Any anecdotal you want to supply with that?
I had the theory for a number of years that sarcoid had to be caused by an immune response to mycobacterial species because it so closely resembles tuberculosis, which is Mycobacterium tuberculosum. And it wasn't until a little over a year ago I finally got the opportunity to try to treat someone with active inflammatory sarcoid. Most of your people you see, they come in and they have stable old disease with just nodules on their chest x-ray, but nothing acute. And so this was the first opportunity I had to test my theory out. Say, oh, you've got active sarcoid symptoms with visual, disturbance and headache and, all these other symptoms. And I gave her the mycobacterial mixture and all of her symptoms went away. So it gave me the opportunity to prove my theory. And it's just, there's something I don't get to see often enough. Well, of course, nobody should have sarcoidosis, so that's not the right way to put it. But, I still just have a couple of cases I've gotten to treat because it's only relevant in the acute setting. But that was exciting to me because I got to prove something that I theorized about.
Yeah, one patient showed up, you treated one, you hit it out of the ballpark. It doesn't get better than this. Let me do this much. I got to take a break. It's a hard break. But I think this is a good way to proceed. When we return, I'm going to dance down this list of 41, some of which you've already talked about and I won't mention, but ones that you hadn't, I am going to mention. I would like my listeners to hear their disease, if they should happen to have it, and feel a ray of sunshine and hope, because in many of these cases, they are out of hope at this point, and they need some. Fair enough, Doctor?
Yeah, that sounds like fun, actually.
Okay. So here we are, folks. We're going to come back in the gun lap in a moment. We're going to take a short break and be back with Dr. Ty Vincent. LDI is the treatment, and the correction is the solution that you can expect. Be right back in a moment with Ty.
Hello, Dr. Dennis Courtney here. Do you or does someone that you know suffer from serious eye disease? Is your vision deteriorating and hampering your ability to drive a car, especially at night? Is your peripheral vision closing in on you? Or how about having to turn your head to the side just to see something directly in front of you? If this seems familiar to you, you'll be happy to learn about a way to restore your vision loss even when your eye doctor may be telling you that nothing can be done. Take the time to find out how you can restore your vision at the Pittsburgh Eye Protocol, a division of Courtney Medical Group located in McMurray, Pennsylvania. It's all part of what we do at the Pittsburgh Eye Protocol. To find out more, you can go to our website at www.pittsburgheyeprotocol.com. You can listen for an announcement for the next free seminar that we offer so you can learn more, or you can just call us at Pittsburgh Eye Protocol. The number is 724-993-0500. That's 724-993-0500, and keep listening on weekends at TW3.
Good morning, ladies and gentlemen. Welcome back once again to the Weekend Wellness Workshop. We're here today discussing a treatment with just great potential and possibility. I think that is fully coming across to you, the listener today, who may be suffering with a host of issues or family members with a host of issues, and they just can't get relief anywhere. The use of LDI, low-dose immunotherapy, may very well be an avenue of pursuit for you, and we're with literally the inventor of such a therapy. His name is Dr. Ty Vincent. He's spending some time with us today while he's visiting the Kona coast of Hawaii we had the opportunity to corral him a bit. Dr. Ty, you still there with us, my friend?
Yes, I am.
Okay. So I think a good way to bring this into the home stretch is to let our listeners know, by virtue of some of the diseases you have been successful with, and as came up with a sarcoidosis, that was one patient that popped up. It's sarcoid. You didn't know for sure whether or not you were going to win or not. You happened to hit the ball over the fence. I take that as a major win, okay, for that particular patient and for you. But here we go. Moving down the list, here's a complicated one. Wegener's granulomatosis. That is a mouthful, but if you've got it, that is a sad mouthful. How'd you do with that one?
Yeah, and I have one person with that we are still in process of seeing how well we can resolve his chronic kidney effects. So this tends to be, it's a vasculitis condition where the immune system mostly is inflaming your blood vessels. And the two areas of focus are the sinuses and the kidneys, oddly enough. And that's kind of what defines this spectrum. There's a related condition that's very similar, but it's different enough that a different doctor put their name on it, and it's called Churg-Strauss disease. And I have that one on the list too. They're basically the same condition with slight differences. The Churg-Strauss patient responded very well, positively to the mycobacterial mixture. This is another one that I sort of hypothesized was most likely mycobacteria because it gets in through the sinus passages where you would inhale the mycobacterial organism. And then the Wegener's manifestation also includes the kidney. So for the one gentleman I have, the trouble with him is that he isn't very symptomatic in a way that you could feel. So we have to track his laboratory data, his kidney function, to be sure whether or not we have the right dose. And so we have the last couple of cycles been able to get his kidney function to improve with the dose we've given him. So we're going to continue it cycle after cycle and see how much improvement we can get with his renal function. The question is whether a part of it is permanent damage at this point or not, because you're not going to reverse that. But if we can keep him from ever ending up on dialysis, that'll be a huge success. That's
the objective. All right, let's move to a different category. This category, well known, has a number of representatives. You call it IBS occasionally, but Crohn's, ulcerative colitis, chronic colitis, these are suffered by so many. As a category, how well are you doing with the category?
That category is complicated. And there's a section in my manual about it, about all the different antigens you might think about in these people, and it's diverse. It's one of these many conditions that I see, these inflammatory situations where a number of different antigens can all trigger the same kind of symptom, and it might be multiple. Overall, I'm probably getting about 80% good, really good success with our inflammatory bowel people. And then there are some stubborn ones out there that we just haven't hit the nail on the head with yet. My guess is one of the things is that they don't have the response to the yeast or the mycobacterial mixtures that a lot of them do. If they respond to those mixtures, we can put them into remission, very, very high success rate. The ones that are reactive to other organisms causing this condition, I try to harvest their own stool and make an autologous mixture. The problem I run into with that is that many of these people have been given courses of antibiotics to treat the acute flares of their disease. And when they're given antibiotics, it often eradicates the organism that I needed in order to treat them. So there's a sort of more significant failure rate in that group, and I think it's because of that phenomenon. And I know that occurs with some of these others because I've had case examples with strep, for example, causing gut-state psoriasis, where I was able to prove that if you get rid of the organism, your autologous sample doesn't work anymore. And in the cases of Crohn's and ulcerative colitis, there are some organisms that can trigger this that we don't yet understand.
Well, I heard you say 80% out of the starting block, and to me, that's a phenomenal number. I know you languish and anguish over the 20% that you haven't hit yet, but I'm going to support this by saying 80% you hit out of the ballpark, and you need to be saluted for it. We move on. Polymyositis, real tragic set of circumstances here with this one.
Yeah, so that, for people who don't know, that's widespread inflammation of your muscles. And your muscles can hurt, but more annoyingly, they just get weak, and people can't even stand up by their own strength after a while. I have 4 cases of polymyositis, And luckily, all 4 of them have responded to some extent, at least, to autologous stool. So there's got to be some enteric bacterium, I figure, that is triggering this in certain people, and it might not be the same one for everybody. I haven't found any research that helps point me to a particular germ to try. So luckily, 4 out of 4 have responded to their own stool to varying degrees. 3 out of the 4 have responded really well, like pretty much getting their strength back to normal. And then 1 is having gradual improvement, but he's complicated. He also has primary biliary cirrhosis, which is a liver inflammatory condition that's autoimmune. And that isn't responding to the same thing that his polymyositis is responding to. So that one's a puzzle still.
Should I say, no, dare I say, we're talking about a list of diseases that has no known treatment in conventional medicine. Can I just make that point, Dr. Ty? I mean, we're dealing with diseases.
They have treatments, but the treatments are in many cases worse than the disease.
Yeah, so
they give you immunosuppressive drugs that predispose you to cancer or life-threatening infection. Like my difficult gentleman with the polymyositis who hasn't had great response yet, he was put on prednisone, which made him worse, also made him gain weight, lose more strength, and made him diabetic transiently until we got him off of it.
Wow.
Then he was put on azathioprine, which has immunosuppressive, side effects and problems, and it did nothing for his disease process. So we're maintaining him without those drugs at this point, and he's gradually improving. But you're right. Yeah. Many of the things on the list had no effective treatment.
None, and we're not going to it won't hurt you with doing LDI. We absolutely can help you, and with the stick-to-itiveness, I don't doubt for a moment that you're not going to figure out the ones that haven't responded. You're going to figure out how to get them to respond. I just know you, Ty. You're not going to give up until it happens. Moving along my list. How about this one? This is a biggie. Chronic pain and fatigue. Is this CFIDs? Is this fibromyalgia? What is this category? This is a big category, by the way.
It is. It's necessarily vague, just to draw people's attention to the idea that just because their syndrome doesn't have a clear diagnosis or name attached to it, it's probably caused by one of these many other antigens. So, they might get diagnosed with fibromyalgia, they might get diagnosed with chronic fatigue syndrome, they might get diagnosed with somatization disorder, like people just think they're crazy, right? That's really common in conventional medicine. All my tests are normal, therefore there's, quote, nothing wrong with you. You hate that. You want to punch the doctor in the face when they tell you that. Most of those people have some kind of chronic inflammatory influence. And the common triggers that I see are yeast, the Lyme bacteria, Epstein-Barr virus, mycoplasma, streptococcus varicella. There's a long list of candidates. So have very good success with these people. And overall, because of my approach anyway, of just trying one thing after another, I talk to everybody for a long period of time and try to dig up historical items that point me in a direction and give me an idea of what like the leading 3 possibilities are. It's usually one of those 3. But you're right, it's necessarily very vague, and that's just so people who don't hear their diagnosis because they don't have one yet. They have only gone to 5 doctors and not 20 just yet, because a lot of people have been to 20 doctors before somebody finally labels them with a diagnosis. Just know this is something that might be the answer for you.
All right. Now let's move to a host of maybe not lethal, but certainly just robbing people of their dignity. A bunch of facial rashes, acne, psoriasis, impetigo, rosacea, the list goes on, unexplained dermatitis. As a category, how are you doing with that category?
So I have to break some of them out. I have one person with discoid lupus early on, like 6 years ago when I was playing with autologous therapies for things. Discoid lupus, for anyone listening who has that, is disfiguring and extremely painful in many cases. These painful purple lesions show up primarily on the face. And this woman had been to 5 dermatologists and no answers, tried all the drugs available, nothing worked. And I took a piece of her own skin off of one of her lesions and dissolved it with a hyaluronidase enzyme and made a dilution, and it completely stopped her disease. It was amazing. And I have before and after pictures of her that I've shown a number of times over the years. So that's one condition that responded to autologous skin sampling. Psoriasis, I would like to talk about, is one of the things that I have to solve before I can allow myself to retire from medicine. I have this incredible antagonistic relationship with psoriasis. But that's because it's an eclectic disease process. It's diverse. It all looks the same, perhaps, but it's caused by such different underlying things that some cases still evade my attempts to treat them. But I think I'm getting closer to nailing them all down. So some cases of psoriasis vanish when you desensitize people to foods. It's that simple. You give them the food mixture. I've seen people with psoriasis from head to toe that is horrific. And they come in a week and their skin's clear because we desensitize them with the regular food mixture. And that one upsets me because it's not supposed to be that easy. It's great for them, but it won't help the next 5 people that I see because most of them don't respond to foods, but it's worth a try. Mm-hmm. Streptococcus causes a certain kind of psoriasis called guttate psoriasis almost every time. And there are other plaque forms that are sometimes triggered by strep. So we use that for a lot of these people. I've tried skin biopsies in streptococcus and really have had no significant success. So that's different. The latest thing I put together, and this covers all those other things on the list just about that you talk about, is a mixture of skin bacteria. And my original thought, and this was a year or 2 ago, was that I should be able to completely fix acne. Because we know the bacterium that triggers acne. It's Propionibacterium acnes. Got a name. We know that it's associated. So as I was going through that process, I decided, well, there are lots of other skin conditions that are probably immune-mediated, bugs on the skin, and why don't I just do some research and put together a list of bacteria that all pool into one mixture, and we just call it our skin bacteria mixture. And so it has Propionibacterium acnes, but there's a couple species of strep and a couple species of staph, and there's Pseudomonas, and there's Acinetobacter and Corynebacterium. These may not sound interesting to anybody, or Peptostreptococcus. There's 12 of them. So we call them dirty dozen of skin bacteria. And we have seen people with weird chronic, it's worked beautifully for acne. Everybody we've treated so far with acne, their skin responds amazingly well. I showed a before, everybody. I showed a before and after picture that was just miraculous at the meeting a couple weeks ago, if you recall. And, other weird dermatitis cases, people with recurring boils, recurring staph boils have stopped getting boils. People with impetigo, because that's streptococcus usually, quit getting it. So it's interesting, these recurring things that we would think of as infections aren't. They're immune response. And then it has not worked yet consistently for psoriasis patients, which is annoying to no end for me. We've had a couple people with psoriasis who have responded to the bacterial mixture. But the next thing I'm going to put together sometime in the next 6 months is a skin fungi mixture. So as I think about this and I get closer, my world is all about, like you said, focusing on failure. And every failure gets me closer to success is my attitude. I have a bumper sticker on my exam table that says, fail until you succeed. And that's the way we approach this. So I'm getting closer to annihilating the psoriasis problem. And the next thing I think is going to work is a fungal mixture, just normal skin fungal flora, because of the way psoriasis looks. It's scaly and red, and that's how fungal infections behave. It's not bacterial. Bacterial infections are more pustular, papular, boils and abscess and stuff like that. And so those conditions seem to respond to the bacterial mixture. And psoriasis, once I put together a list of good candidate fungi from the skin, I think we're going to clear up most of the rest of those cases.
All right, we're gonna hold you to that. Look, it's been fun taking a walk down through these various diseases. I think what comes across loud and clear is, first of all, you're having great successes right now with every single one of them, even though psoriasis, is your big bugaboo. All right, I got you. I hear it. But I will tell you, by the time I see you next, you will have worked this out, and we'll be talking about the successes with psoriasis, because that's where your attention goes. That's you, Ty. That's what makes you you. I want to thank you for being you and doing this yeoman's work, and all of us who are part of this little club appreciate what you do. I thank you so much for coming on the show today and sharing with us and my listeners that ray of sunshine that they just have to see coming through that window. And I look forward to having you back on my show sometime in the near future to talk about other successes that are just around the corner and may be eluding you today. But it is a great pleasure to call you colleague, and I thank you so much. Enjoy your time out at the Kona Coast. When do you go back to Alaska? When does that happen?
I'm here this weekend and all of next week, and then I go back the 1st of November.
You still spend 2 weeks
there now, and 2 weeks every month in each place. This time of year, it starts to get really hard to get on that airplane back to Alaska.
I'll bet you. I'll bet you it does. Okay, my friend, we'll keep in touch. Ladies and gentlemen, I hope you've enjoyed hearing the work of Dr. Ty Vincent. They'll hear more from this fella. I can tell you what, he hasn't stopped making noise. There's going to be more noise coming from him. Thank you very much, Dr. Ty. See you in the near future.